Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing hospice and bereavement with Jennifer Carey, who's a social worker at Care Hospice. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. And also, please remember to leave a review, and 5-star reviews are greatly appreciated. Well, thank you so much for joining us on our show today.
Thank you so much.
So I've, as disclosure, I've worked with Jen for a number of years now. I'm not sure how many, actually. 8 years.
8. She's counting the days.
8 years.
I thought about it.
And I thought you would be the perfect guest today. So today we're going to talk about hospice, but we're going to focus on grief and the difference between, I think, regular run-of-the-mill grief and complicated grief, which is a whole different animal. But why don't you start? Just tell us a little bit about yourself, your training, how you ended up in the hospice field, that type of thing.
Sure. So I went to college and grad school, and, with kind of knowing that I wanted to be a clinical social worker. And my mom is a nurse practitioner, and started the hospice program back home. And so I kind of grew up with, this kind of people calling my house at 2:00 in the morning with my mom. And, we lived in a small town. And so, she always kind of instilled on me the importance of end of life care. Right. And so, I think it kind of felt natural to me to be able to want to go into this field because of that. Obviously her, she was very focused on nursing, but also did a lot of counseling for people for anticipatory grief and, following the death of a loved one. And so I just was really my heart really felt called to the hospice world. And so I've been doing that for the last 20 years.
That's great.
Yeah, it's been such a blessing.
Yeah, and you do a great job too.
Thank you so much.
Perfect for the role.
Thank you.
So we'll take a step back first, just kind of a bird's eye view of just what hospice is in general, and then we'll get a bit more into grief and how we deal with grief. But let's just talk about hospice and what hospice really is. I think most of our viewers probably have some general sense of it, but maybe not.
Sure. So hospice, in a sense, is care for somebody that is facing a life-threatening illness, right? And so, physicians like yourself use their best, ability to kind of identify if somebody is headed in that direction. And hospice is, really geared towards supporting people, patients, and their families when they're kind of entering this journey. And
the end of life, basically.
Exactly. So, we are typically referred when a patient is determined to have 6 months or less, but that's a guess, right?
It's a guess.
Yeah.
We have people on hospice who are on much longer,
exactly.
But that's generally the sense. It's really for patients who have a limited prognosis, right? And so there's a different approach to a hospice patient than, let's say, a patient in my office who was looking for curative care, or a patient in the hospital looking for curative treatment. Right. So maybe we can just talk a little bit about that, because there's a very significant change in the way we approach patients who are going that route versus ones who are looking for curative treatment. Right. Kind of a big pathway division in the way we think about patient care.
Sure. So hospice is the philosophy of, comfort care at end of life, and really kind of addressing both psychosocial pain along with physical pain that's associated with, this end of life journey. And so it's really for people that have decided that they would prefer to focus on comfort measures and kind of be, having some good quality of life with their family and their friends.
Right.
And, kind of being home. And so we, as a team, really support them through that as best as we can.
Right. So in general, we're not doing a lot of, testing or invasive procedures and whatnot that you might do on someone who wasn't facing the end of their time.
Exactly.
So, it all comes down to, like you say, quality of life. And a lot of the things that we do for patients who are pursuing aggressive therapy has an adverse effect on their quality of life.
Sure.
And that's acceptable if you're looking for curative treatment. You can accept some discomfort if you know that, well, what I'm really trying to do here is get over this condition so that I can look forward to a long period of time of life.
Right.
But when you get towards the end of the road, so to speak, where there's like 6 months or so left, it's sometimes not acceptable to deal with those types of symptoms, right?
Right.
Yeah.
That's right. So, our team is made up of nurses, physicians, chaplains, social workers, and home health aides. And, our whole plan of care is to be sure that the patient is, kind of comfortable through whatever symptoms and that they're experiencing, but also for us to be able to kind of provide counseling, kind of anticipatory grief counseling for patients and families to kind of prepare them for, their journey.
So that's a really interesting word you threw out there, anticipatory grief, which I bet a lot of viewers aren't really knowledgeable about. Sure. It's not something we think about. We always think about grief, someone dies, we grieve their loss. But patients actually grieve the loss of their function, their independence, their health. Yeah. And that's how I think about anticipatory grief. Sure.
That's exactly, and that's how I kind of think of that is like, we're there kind of simultaneously experiencing like this kind of, I don't know, more of like, we're trying to kind of help them with, this is what this is going to look like. This is, your disease progression is going to look, a lot like this. And so, kind of walking them through the steps of like loss of independence and, kind of loss of like a connection, however that may be with their family and friends.
Right. So the whole anticipatory grief issue, which I always find very interesting, is it can affect patients, of course, but it can affect family members too. Correct. So you can be a family member who, let's say, one's sibling or mother or husband or wife is ill and moving towards the dying process, or just enrolled in hospice, whatever it may be. You haven't lost that person yet, but there is grief that occurs.
Sure.
For the patient and also for the family member.
Sure.
Yeah.
Just grief associated with the idea that this person is not going to be with us anymore. Right. And so, just kind of like a gentle support around these are such valid feelings, right? We're facing end of life. And so, you as a patient are going to experience all of these feelings, sadness, anger, the whole bit, right? And so are the people who love you,
right.
So kind of.
Because it's a loss.
Yeah, that's
so right. The patient feels a loss. They feel a loss knowing that they're moving towards death. They feel the loss of their health, the loss of maybe they know they're going to be losing that connection with ones that they love.
Sure.
And then on the other end, the family and friends, they grieve also because they know that they're losing someone that they care about too.
That's right. Jen, what are the stages of grief? Sure. So, there's a thought that people go through these 5 stages of grief, right? So it's, the kind of acceptance and denial and bargaining and depression. And so you kind of like the theory would be that you're kind of moving through those steps, right? And it could be that you're doing that while your person is still with you, or you're doing that kind of after, right? After you've lost that person. So, and I think the thought would be, right, that we kind of move through these steps like in a linear fashion, and we don't, right? So, and that can be really kind of alarming to people. Like, I'm feeling so rageful right now and I don't know why, right? But I also think that, with grief, I think people force them, like, I think a lot of times people think like, why am I not like getting over this? Why am I not like more accepting what's going on?
Right.
And really, like, I always encourage people when we're talking about grief, like, nobody's grief looks the same, right?
That's a great point.
And so I think like just being gracious with ourselves and like allowing ourselves like just the ability to kind of like experience these stages however we experience them, right? And so, some people will feel really angry for the first couple of weeks, and we're not moving past that, and that feels kind of like you're stagnant in that, right? But I think, we kind of move through at our own pace.
That's an important point. There's no timeline that is the same for everyone.
Right. That's right.
You know what happens to, like, I've lost people and then you have to go back to work. And all I think about in my brain is I don't want anyone offering me condolences because I'm going to break down. Like, I just want a normal day. Yeah. So there's like my side of grief after losing someone, and there's like that other person that's trying to like extend condolences. Is there any kind of balance there?
It's so hard. It's very hard, Nancy. It is. It's so, I think, as somebody who has experienced grief, right? But also somebody who is really sensitive to when somebody is grieving, has experienced like a tremendous loss. I think, I even walk the fine line of like, I want to know that that I love you so much and I'm thinking of you.
Right.
But I also, I'm careful about that, right? Because I also have to know your people, right? Like if you're, if you're kind of a go through the motions kind of person, like I'll say like, I'm thinking of you. I want you to know that I'm here. And I will do whatever you need me to do. But so it's really hard. It's really hard. I don't think that there's any good answer.
Yeah. No, it is. That's a tough one.
Really tough.
Yeah. And I think so much of this conversation is going to be based on, everyone is a little bit different, but I don't know if there's like broad strokes for like anything, but I'll ask you the questions just the same because maybe they're wrong.
It's probably always okay to say, I know this is a tough time. Yeah. And if you, need anything, I'm sincerely here to help you. I mean, that's okay. That's not going to go awry in any way.
Oh my gosh. I feel like just, it's always so much better to just acknowledge it because I think, we're all, I think, a little awkward around and it makes us all uncomfortable. Death makes us uncomfortable, right? As a society. And
I think it's hard too because you see someone and like, you're like, oh, they look okay. If I say something, am I going to make them like sad when they're having a good moment?
Well, I always,
it's difficult.
Yeah, and I always think that, there are people who aren't going to want to talk about it.
Right.
That they're going to deal with it in a very kind of internal way.
Yeah.
Right? But I think also just letting them know that you recognize that they're going through a difficult time and that you're available and you're concerned. That probably goes a long way.
Yeah.
And they may not want to get into a big conversation, but you may not realize like what an impact that has on them.
Right.
Yeah, it's so true.
Because I think in general, we have a society where people are afraid to extend themselves in that way.
Yeah. Just so, as my role as a visiting nurse, like when I've gone in a home that it has a hospice care team there, one of the most difficult situations that I face is when not everyone's on the same page or they don't want to talk about certain things in front of the mom if she's the one dealing with an imminent death, or they're like, don't talk to her, it will upset her. Like, yeah,
We do get that. sometimes.
yeah, it's frequent.
Especially if the person is capable, they're their own decision maker.
Yeah, that's right.
That's really hard.
So hard. And I think in all of the years of doing this, I have a lot of people say, don't use the H word. Don't use this word.
Exactly.
It's scary. But at the same time, I think I always encourage people to have like a really think about that. I know you're trying to protect your mom, right, from hearing that word, but chances are, based on how she's feeling, how her body is feeling, she probably knows, right? So maybe it would be a helpful conversation to say, how do you feel about this? Like, just kind of open that as a conversation kind of starter, right? Like, I'm feeling nervous about this. You're feeling nervous about it. Like, let's talk about it.
Right.
What?
Because the person can feel very isolated towards
Absolutely.
Well,
They've lost a lot of control.
That's right.
Sometimes the simplest functions we take for granted, bowel, bladder function, ability to ambulate, ability to wash ourselves, clean ourselves, dress, they've lost all of that.
All of it.
So that loss of control is difficult to deal with. And there's a certain amount of grief that goes along with that. Sure. We grieve our loss of health. So these are all really difficult situations.
so what happens again when the kids, first of all, oh my God, I have like 5 questions in my head. Let me start at the beginning. Is grief different in dealing with a nuclear family when it's a child versus a sibling versus an adult parent? Like, what is grief, those kind of stages of grief that you talked about? Is one more predominant with different like ages? Like, how do you talk about grief to a kid?
So it's, I think it really depends on like the stage of development.
Right.
So the way that you're going to talk about, either mom or dad or your grandfather or whoever, it really depends on what's the age of the child, right? So you're kind of if you're dealing with a toddler, you have to kind of talk in these kind of careful terms, right? And I always like to ask the family, like, have they ever had a conversation about death before?
Right.
And what are your beliefs as a family of like where somebody goes?
It's a great question. Yeah.
It is. It's really so individualized, I think, when you're talking about who, like, for kind of what stages people go. I mean, I think everybody ultimately goes through like these grief stages, but we're all so different, right? And in the way that we process things. So I think when I'm doing kind of grief counseling, I just kind of take people for like, where are you right now, right? Where are you right now? What's your understanding of death? What do you hope? What do you, are you having regrets? Are you, all of those things, just kind of encourage conversation.
Jen, for one of the situations that I've been into, and this is a big shout out to people like you and a hospice team, is families, I don't think, realize sometimes that person that's facing death, it needs to be real with someone and not shield themselves. I don't want to say this because it will make my daughter feel sad, or I don't want to let my husband know how bad I'm really feeling, and they're trying to just put on that good. Exactly. Yeah. And like when I walk through the door as a regular nurse, or I'm sure as the hospice team, when you've have developed a different relationship based on what's going on, like one of the things that I get, it's like such a relief just to talk to someone and not worry about how they're going to feel when I say things. I think
sometimes the patient's afraid to talk to
that's right. Exactly.
They don't want to hurt their feelings or make them feel badly.
Yeah.
Very true. And we do see that. But the other thing I'll throw out there, which is really interesting, Nancy, it's a great point that you're making, is I'll just add this to it. There are some real cultural differences too.
Yes.
So there are some cultures where the ill person will defer to a son or a daughter and they don't really want to know anything about what's going on with them.
Right.
And all the decisions, everything will be deferred.
Through, exactly.
And that's fine.
That's right.
That's fine because that's what they want.
Right.
So you don't have to, talk about death or hospice with them because they really don't want to hear that potentially. But that's really alien to us in Western medicine.
Absolutely.
We're not really used to that, but some of the Asian cultures are like that, and it can be very complicated.
Sure.
Jen, what's your approach with families that don't agree with the decision that's made? Like, I'm stopping treatment, or I'm not going to begin treatment because I just want it to go naturally.
So I think I always encourage families to like sit down together, and I'll always offer, can I kind of help create that discussion, right? So, if we have a patient that has said, I am done. I don't want to do that now because the side effects are just too nasty, right, and the outcome for me is not going to be what I want it to be.
Right.
And so, I think I always just encourage kind of an open conversation because I feel like everybody, it's every point, right? That is, every point of view is valid, right? Yeah. Everybody's feeling, right. So
they're coming from their point of truth.
Exactly. Yeah. Exactly. So I always just encourage a conversation around, and like, what conversation is tolerable for a family is so different from situation, right? From situation to situation. And so, I think that's a really hard thing. And deal with that a lot.
We do. And I think that, tell me if you disagree, but if those issues aren't really brought to the forefront and discussed to some extent, it really complicates the grieving process after the person dies. Because now you have all these issues that are, unresolved. Right. And not to say we can resolve all the issues.
No.
People come to hospice with, years and years of relationships, sometimes good, sometimes dysfunctional. Yeah. And the level of function or dysfunction, I think, indicates how hard or easy it may be for them to grieve.
Yeah, agree.
When the time comes. So, but if we can work through some of that, it does help in the long run.
I think it's, I always like to... I think that there's this misconception oftentimes that hospice is like the 11th hour, right? Like, and the person is dying, but I feel like we always love to have people, kind of like sooner rather than later. Exactly. We can develop like these kind of amazing relationships with patients and families. And so you can kind of feel comfortable having those conversations, little by little. Rather than kind of one big whammy,
Usually when patients sign on with you, have they gone through the first stage of grief, or like where is there a common point where you see like this is the most common entry point and this is like where we're catching them mostly, or does it just vary?
I think it varies. I think it varies.
I think we catch people at different points.
I know.
All the time. And, there are families who, they can deal with it in a very good way, and others that really have a difficult time. And we catch people at different points in the stages of where they're grieving. It's all variable.
It is. And, I think a lot of times when we get somebody that has just recently been diagnosed with, a catastrophic illness, right? Where you're kind of dealing with people who are in shock, right? Like, I cannot believe this person was, driving and,
fine yesterday.
Exactly. So I think that, kind of being thrust into those conversations can be really hard for people. Right. And it really depends on, so I think it really depends on like the human spirit, how much, exactly you'd cope with that.
Yep. So you're there for the patient and the family. So if there's someone in the family that is really struggling with this, not the main patient, are you able to provide some extra counseling for that one person?
It's actually part of the hospice benefit.
Yes.
Yeah.
That's one of the beauties of hospice. One of the nice things is that, we maintain these relationships with family members, and it's part of that benefit for a period of time. Is it 1 year?
13 months. Yeah.
That's great.
For 13 months, basically. And I'm sure if it went beyond that, that'd be fine too. But
Absolutely.
13 months
that's
after.
mandated that's by the Medicare benefit, Medicare hospice benefit. It's 13 months.
That's great.
Availability of bereavement counseling.
What's one of the most difficult situations you've been in?
So many.
PrimaCARE is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCARE doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCARE is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCARE is by your side.
Think about that.
Okay.
Yeah. I mean, I think I can tell you.
Of course.
I mean, and this is not specific to any particular person or family, but I think as a physician who's providing medication to families, or not to families, but to patients who are suffering at the end of life, one of the more difficult challenges we have are patients who have a history of opioid abuse syndrome, and also maybe don't have the best life skills as far as dealing with stress and whatnot. That becomes a real challenge, because, you obviously we want to treat their pain and their suffering, but it becomes very difficult sometimes with that history.
Yeah, that's right.
Yeah. And then sometimes there can be some misuse of both medications, which it's hard because you're dealing with a person who's suffering and you want to give them what they want and need, but sometimes what they want is really not what they need.
Right.
And that becomes a real difficult conversation.
Sure.
I think as a physician, that's hard for me. So.
Yeah.
And that, I think, there's so many different situations. Like hospice is one of those kind of fields that you get all kinds of people. Like,
Right.
it kind of runs the gamut. Like
It's a cross-section of society.
Yeah, it's amazing.
Yeah.
It's really like, it's amazing. Because death affects everybody.
Right.
Like,
Right.
it really does. And so I think that, like as Dr. Joncas said, kind of like dealing with, if you have somebody who had, a history of addiction, you're kind of dealing with like social stigma around that, right? And, there's often family dynamics associated with that. And so like having the conversation about like diversion and having to write up contracts, to kind of talk about like narcotic use, is really hard. And it's one of those
very
things
difficult.
It is.
Sometimes it's a family member that's diverting the drug too. It's not always the patient, but sometimes it's complicated because the patient has a history of opioid abuse, or maybe has it has a family member who has an issue. Sure. It becomes really complicated. But just along the same lines, something I think for those watching this to understand is that with hospice, we're not just dealing with physical suffering. There's lots of ways that people suffer throughout their life, but especially towards the end of life. So there's the physical suffering, but there's sometimes spiritual suffering,
absolutely
emotional. I'm leaving one out there: emotional, spiritual, physical. But yeah, there's lots of ways that people suffer, unfortunately. So in hospice, what we try to do is look at the big picture, not just give morphine for pain, but we're trying to treat other things too. And people often, the way they suffer, it's not just the disease, it's how their life has been dealt with up until that point.
That's right.
They may have a lot of underlying issues, unresolved conflicts, family dynamics that are unhealthy, and that all contributes to their suffering also, not necessarily from a physical perspective, but in other ways.
And emotional.
Sometimes the physical pain is amplified by these other issues too.
Absolutely.
So it gets very complicated.
It really does. It's I know it's never one size fits all in hospice. It's just always dealing with different issues. And you can have patients who have the beautiful family and everything kind of went well for them, their entire 90 years. And like we have this kind of unique, gift to be able to kind of like enter the lives of these people, right? To be able to kind of uncover things that maybe they didn't necessarily share with their family, or something that they've been holding, onto that is just unresolved. And it kind of allows, I think, for a patient to kind of, use the team approach to address these issues.
Sometimes there are things that patients have been holding on to for 40 years.
That's right.
50 years.
Right.
Just unresolved issues.
Yes, that's right.
Sometimes you can't resolve them because the person that involved no longer exists.
Yeah,
Sometimes you can't help at least to limit the amount of pain that they're feeling because of those issues.
So sometimes what I see is families being unsure of how to proceed when a diagnosis like this is handed down. They're awkward with talking about anything, or they'll either try to ignore the whole thing, or like, go on a death watch, and like either extreme is like, what are you doing? So, like, how do you navigate families through that? Because those are normal for them to feel.
And I think that's just it, Nancy. Like, just kind of normalizing all of those things, right?
Yeah.
So outside of things like, somebody, expressing suicidal ideation, or somebody, using alcohol or drugs to kind of numb the pain that they're feeling, right? We kind of normalize, like, however you grieve is okay.
Yeah.
You need to like take a minute, and you can't kind of have those really hard conversations. That's okay. But I kind of like, I always encourage people to like have conversations sooner rather than later, right? Like, so that you're having a conversation in a controlled environment when you're not in the middle of a crisis.
Yeah.
And so I really just like to normalize, like, however you deal with it, that's okay. As long as it's not self-destructive.
Right.
Right.
Yeah.
Right.
And I think it's important too that you don't have to be talking every minute, like just to sit in the room and be like reading a book or something, just like you're there,
So absolutely. Filling the silence is something everybody struggles with. Like,
Right.
You want to kind of like, you want to fill that like void. But sometimes I think when people, it's really normal for people that are kind of entering the dying phase to like kind of pull into themselves, right? Like to
Yes.
And so just like being with, and I'll, have family members say like, Jen, I don't know how to be. I don't know how to be right now. And like, I'll say things like, they just like, you just let them know that you're there, and like, like all of the things.
Exactly.
Right. But also just be okay with silence. Like, just be okay with that.
Yeah, it's one of the things that, as hospice physicians, we're trained to be attentive to, but it's so hard when you're in the room with someone. You want to say something, and that silence is so uncomfortable, but it's so important actually to allow that silence to occur.
Absolutely.
So the space is important between the conversation, between the words. So this is interesting. I just looked this up because I knew I was leaving out a few things. We don't think about all these types of suffering.
Yeah.
We think about physical suffering, of course, pain from injury, cancer, whatnot, emotional or psychological suffering we talked about. This is another one we mentioned, existential or spiritual suffering, loss of meaning or purpose. What is the meaning of life? It's like people have crisis in faith sometimes towards the end. But here's something I don't think about sometimes. Social suffering, isolation or social rejection.
Absolutely.
It's interesting. Moral or ethical suffering, guilt, shame, regret over actions taken or not taken. Economic or material suffering, we do see that a lot. We see a lot of our patients who are economically very limited.
Yeah.
And that can be a real challenge for them. And there's one which I've never heard of. You may have as a social worker, vicarious or compassionate suffering. Suffering for witnessing others in pain.
Compassion fatigue, right? Like, I'm sure all of us have experienced it.
Exactly. Yeah, caregiver fatigue actually falls under that. So I guess we do see that all the time. but it's just a term I had not really thought about.
You're right. And I think we only really associate suffering with physical.
But there's other ways. And sometimes those other forms of suffering are just as important.
Yeah.
For a patient.
Or just validating it.
Yeah, just validating it can go a long way.
What else causes a difficult situation for the families that I've seen in my experiences when the person dying tells them, please kill me. I don't want to do this anymore. I have this somewhere and I want you to do this now. And it like the family member is really caught up short. It like, cause they're not, that's like, oh my gosh,
I mean, there's so many reasons that patients feel that way, and you have to explore, like, why do they feel that way?
Right.
Do they have uncontrolled pain? Do they have, in complicated grief, are they grieving the loss of their identity, themselves, their person? But now it's moved from the uncomplicated grief to kind of like major depression.
Yeah.
And that happens. And we see that with caregivers too, or family members. And this is something I'm sure that Jen, deals with all the time when you're doing grief counseling or you're touching base with someone after their loved one has died. Do they have a typical normal grief response? Or does this person now have complicated grief where they meet the criteria more for a depressive illness where, they may be at risk for harming themselves?
Sure.
I almost think that's normal, like for that person, because they just don't want to be there anymore. I can understand where it comes.
I don't think it's the majority of people who want to actually kill themselves, though. I think that's a minority.
To put it out there, I mean, the situations that I've seen it in, they just don't want to do it anymore. They're like, I know what exactly, that's where it's coming from. Exactly. They know what the end is. So why go through another 2 weeks or 3 weeks?
And I think it's a different situation where you're actively looking to
That's right.
your life, I think.
So I think, we kind of as clinicians, all of us, right, have to assess, where is this coming from, right? Like this, and oftentimes, patients will say, I am just done, right? Done with feeling all this pain. I'm done with putting my family in this position where they have to, not work and they have to be here all the time. They have to, change me, care for me, shower me. And I think when you're kind of talking about that, I think it's more like, kind of feeling out, do you have an actual kind of, is there actual suicidal ideation here, or is it a passive desire to die?
Right. That's a big difference.
Right.
And that's kind of the
difference. Yeah. Yeah. It's really hard to feel that out. So if somebody is saying to me, this is my plan and I have means to do X, Y, Z, then you have to kind of feel that out. And have we dealt with that? Absolutely.
Yeah.
Both patients and caregivers. And so just putting a plan in place, but I think it's more that people experience just
overwhelmed,
illness fatigue, right?
Yes. That's great.
It's very common.
Yeah. That's what I see a lot. But yeah,
so normal.
But then you have to separate that out, like you say, from the patients who really have a plan.
That's right.
And they've moved beyond that to a more concerning place.
Right.
And family members for the same.
For sure.
Yes.
There are common threads with families, like things that they can do or say or approaches that they can take in these types of situations. Like, what's the family's role for a loved one?
For a loved one who is expressing this kind of
No, just past this, just in this situation where you have hospice in the home, the families, I know I switched gears on you, I'm sorry. No. The families in the home, and it's just are there helpful tidbits that you can talk about for a family, the way they should act or what they should say or the approach that they should take, or what have you seen families do that you've really thought, wow, this is really beneficial for this patient?
So I think the most, it's interesting because some families, I think, just coming guns a-blazing, I'm going to do this and I'm going to do that.
Yeah.
And then there are families who can't deal with that, right? They can't stop work. They can't, because financially people can't stop working to care for them. So, you kind of see both, but I think like being able to, first of all, identify with the patient. If the patient is able to say, I would really love for somebody to come in and, do my grocery shopping for me, right?
Yeah.
Because I guess it really depends, right? They're losing so much control that like kind of being sensitive to that and encouraging family members to be sensitive to that, or friends or whoever it is.
Right.
Like what I always say, like, ask them, what do you need? What do you need from me? What feels good to you? And then kind of like, as things start to change, because inevitably, right, when patients start to decline, they need more help at home, or, maybe a decision needs to be made in terms of moving somebody elsewhere to a nursing home or, a kind of hospital or whatever the case may be. But, I think just kind of like putting together a schedule, right? Like, who are your people?
Right.
Yeah. And those are really good points. And I think too, sometimes, especially if a person has like a lot of friends, like they don't all have to stop in. Like we get it. We get where you're coming from. We get the love. But maybe if there's like, or like the patient doesn't want to be seen in a certain, like in bed without makeup on or whatever. Like they don't want to have to prepare themselves for a friend that wants to stop by.
That's right.
They just
hosting is
yes, that's a great name.
Sometimes when patients get closer to death too, they start to separate themselves from the outside.
Yes.
Their relationships and their family members, and they, that's actually a common thing you see.
Absolutely. Just kind of
they're not in
retreating.
They retreat. Yes, that's a good word.
Yeah, and like I almost want to like assign a family member, like you be the contact person for the rest of the world, and you let them know.
Spokesperson.
Yes. Yep. Yes. Not accepting visitors.
That's great. Today is off limits.
Yes,
it's true. And you need to have somebody who is, kind of comfortable in that role to kind of be like the bad guy, right? If there are 9 people in the room and the patient can't say, I need you all to beat it.
Right.
Exactly. Person.
Yeah. 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 That's tough.
Just kind of being respectful of that.
Can you go through, because the whole hospice team, the care is such a unique skill. It's not like not everyone can do this. Like I've had nurses that I've been in charge of really struggle when hospice isn't in place. Like you have people struggle because they don't maybe want to give, they don't feel comfortable giving that last injection, or they don't, So can you just go through some of the training that the team get?
That's hard because there's so many different roles. We should probably start with roles on a hospice team.
Yeah.
This is defined by the government, basically who is on a hospice.
But it's very specialized. It's not.
It is.
I think it is, right? So, I mean, from everywhere, from Dr. Joncas, right?
Yeah.
A physician who's skilled in hospice, right. To, having registered nurses who are managing, case managers for a patient. And then, there are chaplains who are also part of the team. And then social workers who are, master's level clinicians.
And then we have our volunteers too, of course. Which is
what's the volunteer role? Do they sit in the phone?
They do. For patient, I mean, it's not hands-on care. Right. So our volunteers are amazing, and so they sometimes they come with skill sets. So we have a volunteer right now who's making little memory bears for patients on their clothing, to give to family members. But then sometimes it's just somebody with a hospice heart who can just sit with.
That's a good way to put it.
Patients,
I love that phrase. Hospice heart.
That's great.
That's a true thing.
Yeah. Yeah, definitely.
So volunteers are just truly they're the heart of our organization, right? And so they could, they can be putting together binders for us, or they can go and, if a family member, for example, needs to go to a church service or something on a Sunday, they'll say, hey, I'm going to block out 4 hours and I'm going to sit with that patient so their family can go.
Gives a little break to the family.
It's great.
It's kind of nice. Yeah, that's very nice. That's an important role, right? Now, what would be like the one message you have for people listening to these steps of grief and hospice and everything?
So I think that it's really important to know that, that our team, right? Like our whole team is there to kind of be supportive to patients and families while you're kind of going through the journey of the disease progression, but then also that we're there afterwards. So like
Correct.
a familiar face, we'll always call and check in with families and just like how are you? And there are times that I'll go to, a family's home and kind of provide bereavement care for the family because they feel like they need it. And, sometimes that's ongoing. Sometimes that's weekly. Sometimes it's, I don't hear for people for a couple of months and they'll say, Jen, I'm really having a hard time. And so it's like this really amazing benefit, I think, of having this and like the beauty of the, kind of hospice.
I mean, it doesn't end when the person dies.
That's right.
The hospice benefit continues, and we're there for the families and the patient too, which I think that's something that maybe many don't understand, that we're there for not just the patient.
That's right.
They are our priority, no doubt, but it's also the family afterwards.
I think that's so important because there's a void, right? Because while the end of care is happening, you're busy with that stuff, and then you're doing all the funeral planning afterwards. And then like 2 weeks later, there's like, mom's not calling you anymore.
Right.
And it's free. And people, our support system after we lose somebody, they are there. They're putting meals in your freezer. They're, kind of offering rides to your kids, right? But then that kind of ends after a month, right? And it's not because people don't care. It's because they're hoping that you're kind of moving through, right? And I think you learn how to like live with grief rather than get over it. You know what I mean? You kind of learn how to integrate grief into your life. And I think having, support that is there and is skilled to help you kind of through that is helpful.
Absolutely.
Those people.
I would say, from my perspective as a hospice, physician, the message I'd want to get out there is that, as Jen mentioned, hospice can be incredibly valuable, not just to the patient, but to the family. But we can do more if we're on board earlier. And a lot of times what happens, quite frankly, is we're involved 2 days before the patient dies. And we're not able to really establish those relationships with the family or the patient that we would have otherwise if we had more time. So I think that's one message, is don't be afraid to get hospice involved early if you do think that you're interested in more of an approach where you're looking at comfort and quality of life rather than active treatment. The earlier you do that, and the more we'll be able to do for you. That's really an important thing.
When's the first time hospice is offered?
What do you mean?
To families. Like that has to, like if you're in the hospital, you have hospice, but if
it could be
go in for testing to your doctor's office.
Be referred from your primary, from a specialist while you're in the hospital. There's so many different ways that hospice can be brought up. Usually by a physician, but sometimes by a nurse or by a social worker. It can be, there's a number of ways that you can end up having that conversation.
Okay.
Yeah, but that would be one thing I would say. I would also say that keep in mind if you're grieving that, grief is different for everyone, and you can grieve before the person dies, and that's okay. And if you are the person, you can grieve your loss before you die. Yeah, so patients grieve. They're grieving their loss. Families grieve before the patient dies because they see what's coming. Yeah. And then they grieve afterwards. There's all these different types of grief. Grief is different for everyone. There's no one roadmap. Everyone is going to deal with this in a different way. And that's okay. Yeah. That's fine. That's fine. But you have to also recognize if you've moved from what we consider to be normal, uncomplicated grief to more complicated grief, where now you're actively suicidal and you're thinking about ending your life, and you have more symptoms that seem consistent with more of like what we call a major depression, then you really need to reach out to your healthcare provider and ask for some help.
That's right. Yeah, we kind of deal with people who are kind of we're identifying them as high risk, right? For grief and bereavement. And really what that means is, you're kind of taking a look at like the person as a whole, right? So you're saying, geez, I don't know what their support system looks like. Do they have good friends? Do they have good family around them? Do they have people that they can talk to? Do they have stability financially? Do they have, all of those things? How are they medically?
Time you can sort that out, but
Exactly.
if you meet the person 2 days before they pass, it's so hard.
It's so hard. It's so hard. You're right. So we're kind of like getting as much information as we can. And, the home environment is so helpful for us to be able to go in and just, be able to, because your home often is like such a reflection of you, right?
Right.
So yeah, it's really, we do our best to be able to identify who's at risk.
Yeah.
Nice.
Really an amazing conversation, Jen. Thank you so much. This was great.
Oh, thank you for having me.
Do you have any other questions?
I am done with my questions, but I am just like so happy that you were here to talk about this, because I think it's awareness is much needed.
Yeah.
Thank you both so much.
Yeah, thanks for coming, Jen. I mean, it's great to talk about this. It's great to talk about hospice in general. Such an underutilized service, unfortunately. So,
Well,
thank you everyone for watching our show. And if you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. PrimaCARE, your trusted medical providers in southeastern New England. Bioskills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. And our sponsors, Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And Jen, of course, thank you so much for being our guest and enlightening us about hospice and bereavement and grief and all of these really important topics that often don't get discussed.
It's such a pleasure. Thank you both so much. Thank you.